our next speaker is Dr. Adrian Boyle. Adrian is a distinguished British emergency physician and consultant known for his tireless advocacy for enhanced healthcare and emergency care reform in the UK. And in October 22, he became the President of the Royal College of Emergency Medicine. Dr. Boyle's leadership and candid insights have been instrumental in addressing critical issues within the NHS and the healthcare sector. And again, I would say, my personal reflection here, reading your Wikipedia page, in fact, that it's a physician who hasn't remained static, but wishes to use their expertise for the benefits of patients and the healthcare system. And it's a reflection that I was thinking about late last night, is that sometimes as clinicians we are so engrossed in the day-to-day work that we face, the firefighting that we have in our GP clinics and our hospital clinics, that sometimes we need to also look at how the system needs to be improved and changed, and how we can make things better for our patients. So our real honour to host Dr. Boyle tonight. Thank you, Adrian.
I look at you to move on this slide, so you're the most important person for this, okay? Thank you, this is a huge privilege to come and talk tonight. This is really difficult to follow Jane Kumar. I grew up reading her books, and she's probably getting partly sick over me telling how valuable books are, but it is truly useful. So I'm going to talk to you a little bit about what it's like being a Royal College president. I became president by election almost exactly a year ago, and I was sent this message, so if we just go to the next slide. I got sent this message by a friend, and I'm just going to play it to you. My predecessor was somebody called Catherine Henderson. But hopefully you'll be able to see this if you just press play on that message.
Medicine. It's Dr. Joachim Flecken. I'm coming to you from Portland, Oregon. I just finished an eye clinic where I examined like 40 different patients. I did so many eye exams today, and that probably sounds terrible to all of you. And frankly, it wasn't really that much fun for me today either. But I had to take a moment to record this video. First, just to say thank you to Catherine Henderson, the outgoing president of the Royal College of Emergency Medicine. Done a fantastic job, has worked really hard to get the RCE and where it is today. And to also welcome Adrian Boyle. Adrian's coming in. He's going to do a fantastic job as the incoming president. You know how I know Adrian's going to do a fantastic job? Because I saw him on live TV wearing a dressing gown. You know that he has his priorities straight, because really what he was just thinking about this new role and what he can do to help all of you. He wasn't even thinking, about wearing normal clothing and something that's presentable in public. It doesn't, that's secondary, all right? And that shows you just how awesome he's going to be in this role as president. And so, I know that the Royal College, hello to the UK Royal College.
Okay, and this may feel like a bit of an in-joke, but that is why you should never agree to do an interview at 6 o'clock in the morning for talk radio, and they say, oh yeah, FaceTime's not working, let's go to Zoom, and you're there, having gone to bed at midnight, getting up at 6 o'clock to do the interview, and that's what happens.
Hello?
So, this summer, I was really lucky to go to the International Conference in Emergency Medicine. It's a big international conference, and we had a president's meeting, and this is me at the back of the room of all the Royal College, the College of Emergency Medicine Societies all around the world, talking about what our problems were and how we were trying to deal with it. And it was fascinating. But actually, if we all come up with the same things. We have 3 main priorities. Our priorities are about the well-being and retention of our workforce, the crowding in our departments, and also, particularly for emergency medicine, professional respect and identity that we, because we're a young specialty. I work in a hospital where frequently people go, oh, you're a consultant in emergency medicine. What are you going to do when you've finished your training? When I said to my mother that I was going to be an emergency medicine specialist, an emergency physician, she said, well, what will I tell my friends? I was, beforehand, training to be a cardiologist, and she was so proud. She's less proud now. Okay, that is the identity of the emergency physicians, if you're not sure. So my job as President of the Royal College of Emergency Medicine is to represent my members. And on the 1st of January, I told Times Radio that I thought the current situation in our emergency departments over the winter, with ambulances streaming out, stuck, unable to hand over, long waits inside, people being looked after on corridors, was associated with 300 to 500 deaths per week. This is not new data, and we had said this previously several times before, but everybody ignored it. Somehow this just hit a nerve, and the media went absolutely, there was a frenzy. It was like throwing something into a fish tank, meat into a fish tank. It was a real frenzy. Since that interview, I have given over 500 interviews trying to explain what the problems are, but also, importantly, what can be done about these problems. I was not making this up. This was based on scientific data. So this is a paper that was published in our scientific journal. It shows gradual increasing risk of mortality in people who are being admitted to hospital across the entire NHS England data set. It's adjusted for age, it's adjusted for comorbidity, but it shows a very clear theme that once you go over about 6 hours of waiting in an emergency department to be admitted, your risk of mortality goes up. So for every 75 people who wait up to 12 hours in an emergency department before being admitted, there is 1 additional death. So I get challenged about this a lot. This was obviously driving the media frenzy. We were very consistent. We made sure constantly that we were confident in our stats. I ran it by my research committee. I was challenged. People did not want to hear this. This felt very uncomfortable. I was hauled in front of the Health and Social Care Select Committee. I had Radio 4 interviews where people say, are you really sure about this? And there would be eminent professors of statistics were asked their opinions. So a guy called Professor David Spiegelhauser, he's a professor of medical statistics at Cambridge University, came on the next day and said, yeah, I actually think what they've done is entirely appropriate and real. It feels very uncomfortable being that far ahead, being slightly isolated, with saying people stuff that people don't want to hear. But it gains attention. And this is me with one of my vice presidents in Higginson. Those of you who know him will find this quite an unusual photo because he is famously scruffy. He's wearing a suit, so this photo is a collector's item. But we have been invited in several times to explain why we are concerned to the politicians and what we think should be done about it. I'm in a situation where I have weekly meetings with civil servants about problems within emergency care, and what we say is listened to. And one of the things I've learned in my first year being a college president is if you want people to listen to you, you have to be quite outspoken. You can do an awful lot of meetings behind the scenes, but actually it's important sometimes to make people realise they have to listen to you. So I often get challenged, well, you're doing all of these things, what's coming out of it? Well, I think my biggest achievement is stopping people doing stupid stuff. So those of you who work within the NHS will be aware there is an awful lot of stupid stuff which is being put forward. You know, we are absolutely supportive of things which have been properly piloted, properly developed and actually done. But I hope, do you all remember that big plan last year to encourage, as getting ready for winter, to to have everyone be encouraged to use NHS 111 online. You all remember it? No. Good. Thank me. Because I spent 5 days trying to stop it because it's a terrible idea. It will just increase more people going to emergency departments, more people calling ambulances, and more people being sent to their GP when they don't need it. Okay, so I noticed that the key aim of the Heritage Centre is health inequalities. My specialty is only really beginning to scratch the surface of what we have around health inequalities. And I think there is a big piece of work for us to try and understand this. We know that there is a gender difference to people's inequality, risk of surviving after major injury. But we've got more work to do. This shows the long waits that are being endured by our elderly patients at the moment. If you were over 80 and went to an emergency department in 2022, your average length of stay was 15 hours. This is not kind, this is not good for patients, it makes them delirious and it makes them unwell. So these figures, we keep pushing. Okay, so I always get asked about what do you think about the 4-hour target? Well, I think the 4-hour target is terrible. And a number of years ago, people were, and we all see it puts lots of pressure on people to do things, it sours relationships between professional groups within hospitals. And we tried an experiment to get rid of it a couple of years ago. And what did we learn? There isn't anything better. Okay, so we tried it, but there isn't anything better. And when you take a 4-way target, take it away, what you find is that you end up with people staying even longer and people getting more disadvantaged. And the people who suffer when you take away a 4 target are the people with mental health problems and the people who are elderly. I've also got a job to try and explain what happens in hospitals and what happens in emergency departments. Because doctors are terrible because we always think we know what everybody else does. And people really don't know what goes on in other parts. I would not pretend to understand what happens in a cardiac cath lab or in a colonoscopy suite. This is one way of trying to illustrate what goes on in an emergency department. We send lots of people home. 75% of people go into emergencies and get sent home. Our biggest group of patients now are majors ambulance patients. Those are the biggest group of people coming to emergency departments now. I would hesitate to describe them as emergencies, and I think most of them will be described as urgent care. The patients I'm most worried about are the patients where the harm is greatest, and those are the patients who need to be admitted and are on trolleys. But then look at what happens on the next slide. The dominant admitting specialty in most of our hospitals is medicine, by a long way. General medicine dominates admissions, and increasingly everybody is being admitted under medicine. At a time when people want to do general medicine less and less, and because it's become really hard work, professionally unsatisfying, and not valued. So I advocate particularly for these groups. I call them the special queues because I know that if you have blank policies, nobody else is going to advocate for these. Okay, this is me in the summer, just talking about various workforce issues. I had a major case of imposter syndrome with this. I walked in, I saw the seating plan that was put in front of Steve Barclay and Rishi Sunak. My name's written in red and circled. The head of a nuclear power has my name on a list with a circle around it. It was not a comfortable moment. So I think I've had some success this year. It's difficult to know how much of it's mine, because in the policy world, it's often building a consensus and no one can really claim credit for it. We've got clarity around the way we record 12-hour length of stays in emergency departments, which is a good thing. We've also got clarity that we're not going to try and do anything other than the 4-hour target, which I think is a good thing. I hope we're moving away the narrative that whenever we have a problem in emergency department, it's not because of inappropriate attenders and demand management. It's actually about our capacity within hospitals, our number of beds, and our perpetual failure to fix the problems with social care. I think there's an increasing recognition that the NHS is underbedded and understaffed. And it's a high political priority. My stated unofficial mission aim is that Steve Barclay, when he goes to bed at night, closes his eyes and he sees queues of ambulances, he wakes up having had a nightmare about corridor care. That's my job. So we have this crystal ball at the college, and I've had a good look into it. I think we're going to have a tough winter this year. I think industrial action is going to grumble away and we're all going to feel pretty sour about it. I'm worried that that's going to cause sourness and difficulty between specialties, between professions, but most importantly between our relationship as a profession and the public. I remember being a doctor in the 1990s. We were seen as incompetent and elitist and unpleasant. Every headline about doctors in the 1990s started with the phrase, bungling doctors. Do you remember those? We've got where we have become much nicer, much more patient-centred over the last 30 years, and I'm worried that the strikes are burning that currency. We have a general election. There's going to be health is going to be a key part in a key election battlefield. How we position ourselves and advocate best for our patients is going to be dynamic and interesting. The comments I had when I was accused about being static, when facts change, we have to change. I put up this slide at the end to show what it means to me to be an emergency physician. The doctors I train and the doctors I work with, we are the only doctors who can do all of these things, whether it be a dislocated shoulder, respond to a mental health crisis, or my personal favourite, which is removing a nasal foreign body from a toddler. Thank you very much.